wonderful cases. With this, we now move on to another topic which bothers us all the time in uveitis practice, which is uveitic macular edema. What to do when it's persistent? So I call upon Dr. Padmamalini, Mahendradas, to be speaking on this topic. Please keep your questions ready, so we'll have them up during the panel discussion.
Good afternoon to all of you. And outside, I'd like to thank Dr. Rima for inviting me here today to speak on uveitic macular edema, what to do when persistent. Macular edema is a macular thickening due to abnormal leakage, accumulation of fluid in the macular area, owing to the breakdown of outer and inner retinal barrier, leading to increased permeability of the retinal pigment epithelium and retinal vasculature. It causes severe impairment up to 30% in uveitic patients. Macular edema is considered persistent if the retinal thickness persists even after 6 months of treatment. The macular edema varies between different types of uveitis, the commonly seen in pan-uveitis, followed by intermediate uveitis. Coming to the risk factors, it could be secondary to systemic or local risk factors. The systemic have associated diabetes, hypertension, or smoking, obesity, and increasing age. Coming to the local risk factors, the breakage of the retinal barrier alterations, recent history of intraocular surgery, or associated with inflammatory choroidal neovascular membrane or presence of epiretinal membrane causing the traction. Coming to the pathophysiology, there is a loss of equilibrium between the water influx and efflux. Increased influx of fluid, breach in the blood-retinal barrier, which causes increased oncotic pressure, causes vasogenic edema, activation of Muller cells, decrease in PDGF, increase in VGGF, and increase in inflammatory parameters like TNF-alpha, interleukin, and prostaglandins. Decreased efflux of fluid occurs Muller cell dysfunction, and also the microglial cell activation and RPE dysfunction results in cytotoxic edema. When there is a presence of vasogenic as well as cytotoxic edema, results in uveitic macular edema. So it's important we need to understand what is the pathogenesis occurring in each case. Accordingly, we have to plan our treatment. Coming to types of macular edema, uveitic macular edema, it could be a cystoid macular edema, which commonly we see, or diffuse macular edema, cystoid macular edema associated with subretinal fluid. And now we'll move on to case examples. This instruction course is based on the cases, so now we'll see cases. First, case 1 is a case of a persistent macular edema. It's a 47-year male diagnosed to have a case of bilateral retinal vasculitis with cystoid macular edema on treatment since 2 years before the patient presented to us. He gave history of treatment with oral azathioprine, then switched over to oral mycophenolate meftil. Patient received multiple local posterior subtenon injections and intravitreal anti-VEGF agents. At presentation to us, the patient was on treatment with mycophenolate meftil, methotrexate. When we investigated what was the reason, the patient had lupus antibody was positive, whereas other investigations were negative. This is a clinical picture. The visual acuity at presentation was 618 pads in the right eye, 6/9 in the left eye. Anterior segment was quiet, lens was clear. We could see the vitreous haze, posterior vitreous detachment, and also we can see a focal areas of vasculitis with chorioretinal laser marks in both eyes. When we did the OCT, we did notice cystoid macular edema with subretinal fluid in the right eye. In the left eye, we could see ERM with intraretinal cystic spaces with subretinal fluid. Both eye, the patient received anti-VEGF with continuation of systemic therapy. FFA showed perivascular leak, disc leak, and staining of the vessels with capillary non-perfusion areas. This is a late phase showing the disc leak and staining of the vessels and leakage from the retinal vessels. In spite of anti-VEGF therapy, there was recurrence of macular edema. Always there was some amount of cystic spaces were persistent in both eyes. So when we referred the patient to the rheumatologist, systemic evaluation was done based on the systemic parameters. They decided to go ahead with a rituximab injection for this patient. Following rituximab, we could see reduction in the macular edema. However, there was persistence of cystic spaces. We discussed and we went ahead with intravitreal Osidex, and MMF was changed into cyclosporine. So following which we could see the resolution of the macular edema. However, the patient has become steroid responder. Then injection adalimumab was continued, started, and however, there was inadequate response to adalimumab also. So we did the inflammatory cytokines from the cures, and we did notice interleukin-6 was elevated. Discussed with the rheumatologist, we started on injection tocilizumab. So following the tocilizumab, we could see the resolution of the macular edema and resolving edema in the right eye. This is at presentation. Patient had MMF with methotrexate. Anti-VEGF did not respond. Rituximab did not respond to satisfactory results. Osidex was okay, but however, the intraocular pressure was went up. Adalimumab, we did not get satisfactory response. Finally, the patient responded to tocilizumab. Next case is a persistent macular edema, 56-year female, presented with transient blurring of vision in the right eye for 6 months. History of fever 2 weeks back, where we could see the central retinal vein occlusion in the right eye with macular edema in the right eye. Left eye OCT was normal. FFA shows block fluorescence corresponding to the areas of retinal hemorrhages in the right eye. In the late phase, we could see the disc leak, staining of the vessels with leakage. And this is a diffuse perivascular leak with a disc leak in the late phase. When we investigated, dengue, IgG, IgM was positive. Serum ferritin was elevated. HLA-B51 was also positive. IGRA was indeterminate. We started the patient on oral steroids. Immunosuppressions with methotrexate was started. Anti-VEGF was given injection. Avastin was given to the right eye. Subsequently, we can see the resolving macular edema in the right eye. 2 months post anti-VEGF, again there was a flare-up of macular edema, advised Osidex. Patient developed steroid responder. It was okay. Once the effect is over, the macular edema started appearing again. Advised intravitreal anti-VEGF. Post 1 month anti-VEGF, we could see the resolving macular edema. Again, the macular edema bounced back. 2 months anti-VEGF, repeat intravitreal anti-VEGF agents. Following which, we could see the resolving. Started on systemic cyclosporine, intravitreal anti-VEGF, methotrexate, cyclosporine, and intravitreal thing. With that, the patient this is the course of action. Recurrence, steroid response, anti-VEGF, post-anti-VEGF, and now the patient last 1 month they're doing well with cyclosporine. The next case is a persistent macular edema, 60-year male, defective vision since 3 months, treated with ATT and oral steroids for retinal vasculitis. Here again, the patient is a steroid responder on oral methotrexate as well. This is a fundus photograph. Right eye had posterior subcapsular, left eye was a pseudophakia. OCT shows lamellar macular hole with intraretinal cystic spaces in the left eye. So we have used topical interferon for uveitic macular edema. We have published our results in Indian Journal of Ophthalmology. We have tried topical interferon therapy for this patient, following which we could see the resolving macular edema. Coming to the treatment algorithm for macular edema, first we need to see whether it's infectious or non-infectious. If it's infectious, in addition to antimicrobial and anti-inflammatory therapy, we can control the edema. Whereas in non-infectious uveitis, it is chronic. First line will be the corticosteroid therapy. If the patient is not responding, second line we can use immunosuppressive therapy. Either it could be methotrexate, azathioprine, MMF, or cyclosporine. If they're not responding, then anti-TNF agents. We also started using interferon alpha topical therapy. In addition to that, we can combine with intravitreal dexamethasone implant or anti-VEGF to control the macular edema. Coming to the bilateral thing or unilateral. Unilateral, again, if it's mild, treat them with periocular steroids or intravitreal steroids. It's moderate, we go for the intravitreal steroids or systemic therapy. In bilateral, again, the similar sequence, steroids or intravitreal implant, systemic immunosuppressive therapy, anti-TNF, and refractory cases, we find topical interferon is found to be effective. Earlier we were using 4 times a day. Now we started increasing the frequency up to 6 times a day, and they respond well to treatment. Coming to the treatment, we treat them with topical, local or systemic therapy depending upon the type of the uveitis and the severity of the macular edema. Topical NSAIDs work well for mild post-op uveitis. The topical steroids, difluroprednate, has a penetration into the posterior segment, effective in controlling the macular edema, and topical interferon also is useful. Coming to the local therapy, it could be the periocular or intraocular steroids, anti-VEGF agents, and anti-TNF intravitreal agents also can be used to control the macular edema. Coming to systemic therapy, we use systemic steroids, immunosuppressives, biologics, and refractory cases, tocilizumab, IL-6 inhibitor is found to be effective in treating chronic refractory macular edema. I'd like to acknowledge my colleagues for the contribution. Thank you for your attention.
Thank you very much, Dr. Padma.